I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield. And we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. As we know from our previous episode, gestational trophoblastic disease is an umbrella term for a group of diseases that can be benign or malignant. Last week we covered the benign conditions of complete and partial molar pregnancy. Today we'll move on to the malignant group of gestational trophoblastic disease, otherwise known as gestational trophoblastic neoplasia, or GTN. So what do we know about GTN?
Gestational trophoblastic neoplasia refers to a group of tumours with the potential for local invasion and metastasis. It includes 4 different conditions: choriocarcinoma, placental site trophoblastic tumour, epithelioid trophoblastic tumour, and invasive mole. Each of these neoplasms can occur after a normal pregnancy or a molar pregnancy. When we're talking about those that develop after a hydatidiform mole, we tend to use the terms GTN or invasive mole, so we'll focus predominantly on that today.
Last week, we spoke about gestational trophoblastic disease, and one of the key points we made was the difference between a complete and a partial mole, particularly with regards to the risk of progression to malignancy. Anne, can you refresh our memory?
Sure. So a complete mole is a diploid pregnancy that occurs when 2 sperm fertilize an empty egg. It contains no maternal genetic material, and so P57 is negative. It has no fetal parts. A complete mole has a 15 to 20% risk of progression to GTN. A partial mole occurs when 2 sperm fertilize 1 egg and is triploid. It contains both fetal parts and maternal genes, and so P57 is positive. The risk of a partial mole progressing to GTN is 1 to 5%. And it's because of this risk of a molar pregnancy progressing to GTN that we need to do bhCG follow-up. How long do we need to do that for again?
Well, if you're following the RANZCOG guideline, it's weekly beta-HCG until negative for 3 weeks for a partial mole, and then monthly for 6 months for a complete mole. If you're following the Green Top guidelines, then it's weekly until the beta-HCG is negative. For a partial mole, you then do 1 repeat beta-HCG in 1 month, and for a complete mole, it depends how quickly the beta-HCG reverted to normal. If the beta-HCG normalized within 56 days, then you do a monthly beta-HCG for 6 months from the date of suction D&C. If the beta-HCG normalized after 56 days, you do monthly beta-HCG for 6 months from the day the beta-HCG is negative.
So what exactly are we looking for with this follow-up? What might suggest to us that someone is developing GTN?
Features that suggest persistent trophoblastic disease include a rising beta-HCG more than 10% across 3 values over a 2-week period, a plateaued beta-HCG that remains within 10% over 3 consecutive measurements, and continued vaginal bleeding with a detectable beta-HCG. If any of these features are suspected, then it's likely the patient has developed gestational trophoblastic neoplasia, and she should be referred to the Trophoblastic Centre or a gyneacologist.
So is there anyone who might be more likely to develop GTN? What are the risk factors for progression to gestational trophoblastic neoplasia?
Women at higher risk of progression to GTN include those with an older age, a longer interval from the previous pregnancy, and those with higher beta-HCG levels. Women over the age of 40 have a 30 to 60% risk of progression to GTN. Obviously, those with a complete mole are more likely to progress than those with a partial mole. There are also several features of the molar pregnancy that increase the risk of progression. These include uterine size greater than gestational age, serum HCG over 100,000, ovarian thecal lutein cysts greater than 6 centimeters, previous caesarean birth, and those who take a longer time to reach a negative beta-HCG after evacuation. Although most cases of GTN develop in high-risk patients, it can occur after any molar pregnancy, and so beta-HCG follow-up is important for everyone, regardless of whether they have risk factors or not.
So let's work through gestational trophoblastic neoplasia with a case. Today we have Alex. Alex is a 35-year-old G2P1 who recently underwent a suction D&C for a complete molar pregnancy. She was referred to the local trophoblastic centre and has been having weekly beta-HCG follow-up. You were reviewing her results and you noticed that her most recent beta-HCG didn't seem to drop very much. Last week it was 13,000 and today it's 12,500. What do you do?
Well, firstly, I would be suspicious that the beta-HCG is plateauing. However, we would need to do one more beta-HCG to be sure. Technically, the criteria for concern is a drop of less than 10% over 3 consecutive values in a 2-week period. So I would repeat the beta-HCG in 1 week. I would also assess her clinically for any symptoms that might suggest GTN.
And what kind of symptoms might you be looking for?
Well, firstly, I'd asked about symptoms related to elevated beta-HCG, like hypothyroidism or excessive vomiting. Alex might also report pelvic pain or pressure if she has an enlarged uterus or ovarian thecal lutein cysts. Next, I'd asked about any symptoms that might relate to metastatic disease. Breathlessness, chest pain, cough, or hemoptysis might suggest lung mets. Abnormal vaginal bleeding or purulent vaginal discharge might suggest vaginal mets. And headache, dizziness, seizures, and neurological symptoms may indicate raised intracranial pressure due to hemorrhage from brain metastases.
So you take a thorough history and Alex is asymptomatic. She goes ahead and has her repeat beta-HCG next week. This time it's 12,000. What do you do now?
So now we can see that we have a plateauing beta-HCG. The beta-HCG has failed to drop over 10% over 2 weeks, or 3 consecutive values. For those of you who want to do the maths, a drop from 13,000 to 12,000 is an 8% drop. I'd now be suspicious for persistent trophoblastic disease or GTN. I guess my next step is to tell Alex. I would explain that her beta-HCG hasn't quite dropped as much as we'd like it to, and as a result, we're worried about persistent trophoblastic disease. Our next step would be to arrange staging investigations and refer Alex onto gyneacology for an MDT review of her case. Alex can likely expect to be treated with chemotherapy and should be advised that there is an almost 100% cure rate. Being diagnosed with persistent GTD can be a really scary time, and so it's important to take the time to explain the next steps and to provide her some kind of reassurance. Directing her to patient support websites can be really helpful.
So you mentioned that we would need to arrange staging investigations. How exactly should we go about our workup for GTN?
The typical workup involves examination, bloods, and imaging. A thorough pelvic examination should be performed to assess for the presence of a bulky uterus and vaginal metastases. These usually look like little vascular lesions. If you're examining a patient post-molar pregnancy and you see a lesion in the vagina that is suspicious for a metastatic deposit, you should absolutely not biopsy it. These lesions are notorious for causing significant bleeding. If you suspect a vaginal met, leave it alone.
Does this mean we shouldn't biopsy any metastatic deposit?
Well, with other malignancies, obtaining a tissue diagnosis is really important to help determine treatment. GTN is a bit of an exception to the rule. Biopsies can cause significant hemorrhage, and so we tend to avoid performing them. The diagnosis of GTN can actually be made clinically.
Okay, so moving on to the next part of our workup. We've done our examination, now we need to organise some blood tests. Blood tests include thyroid function tests if the HCG is more than 100,000 to assess for hypothyroidism, and liver function tests to assess for liver metastases. Renal function tests should also be performed to exclude renal dysfunction prior to chemotherapy, and also because placental site trophoblastic tumour or epithelioid trophoblastic tumour can occasionally be associated with nephrotic syndrome. If there's any evidence of virilization, then serum testosterone should also be performed.
Imaging includes a pelvic ultrasound and a chest x-ray. A pelvic ultrasound might show one or more poorly defined hypervascular masses in the uterus that invade into the myometrium. Chest x-ray is performed to assess for pulmonary mets. It can be tempting to go straight to a CT scan. However, this isn't necessary if the chest x-ray is normal. Sure, you might miss microscopic metastatic disease, which usually occur in about 40% of patients, but this really doesn't affect the treatment or prognosis, so you should really stick with a chest x-ray and only organise further imaging if this demonstrates obvious pulmonary metastatic disease. GTN spreads through the blood and is most likely to metastasise to the lungs and the vagina. In the absence of lung and vaginal mets, it's really unlikely that there would be metastasis to any other sites, but they could, in theory, occur in the liver, brain, spleen, or gastrointestinal tract. If pulmonary mets are detected, then you should arrange a CT chest abdo-pelvis and a PET and MRI brain to assess for widespread metastatic disease.
So once we've done our staging investigations, what do we use to classify GTN? Do we use the normal FIGO staging?
GTN is typically staged using a combination of the FIGO staging system and the World Health Organization prognostic scoring system. Stage 1 is defined as persistently elevated beta-HCG with tumour confined to the uterus. Stage 2 is where the tumour extends to the adnexa of vagina. Stage 3 includes pulmonary metastases on chest X-ray. And Stage 4 includes metastatic disease outside the lungs, pelvis, and vagina.
Probably what is more useful is the WHO prognostic score. This scoring system is basically used to stratify the patient as high or low risk of drug resistance in order to guide the chemotherapy regime. The WHO prognostic score includes 8 risk factors that have been shown to predict the development of resistance to single-agent chemotherapy. These are features that you would do well to remember because they seem to make a sneak appearance in exams every now and then. These include age, antecedent pregnancy, the interval from the index pregnancy in months, beta-HCG level, size of the largest tumour in centimetres, site of metastases, the number of metastases, and whether she's failed chemo before or not.
A score of under 6 means the woman is at low risk of chemotherapy resistance, whereas a score of 7 or more indicates a high risk of chemotherapy resistance and requires combination therapy. A score of 12 or more is considered ultra high risk and is probably the worst prognostic group. This group is associated with non-molar antecedent pregnancy, brain mets, and failed prior multi-agent chemotherapy. The 5-year survival in this group is only about 68%.
Now, it's important to note that the WHO prognostic scoring system is not used for patients with a placental site trophoblastic tumour or epithelioid trophoblastic tumour. These tumours have a different pathobiology and are managed differently than invasive mole and choriocarcinoma.
Okay, so Alex is 35. It was a previous molar pregnancy. Her beta-HCG is 12,000, and she has a 4-centimetre pulmonary metastatic tumour with no evidence of other meds. It's been 4 months since suction evacuation. You check the chart and calculate that Alex has a WHO prognostic score of 6, indicating a low risk of single-agent chemotherapy resistance. Which chemotherapy agent would you use, and how would you prescribe it?
Women with a WHO prognostic score of less than 6 are suitable for single-agent chemotherapy with either methotrexate or actinomycin D. Complete remission can be expected in about 90 to 100% of patients with low-risk GTN and single-agent therapy. Typically, methotrexate is preferred over actinomycin D because it is effective, well-tolerated, and cost-effective, although there is no real consensus over which single-agent regimen should be used because both appear to have excellent results. In Queensland, most facilities use actinomycin D because the regime is a little less intensive, and some studies have described slightly higher efficacy. Now, we are not going to pretend to know what the gyneacologists do, as this is definitely their area of expertise. So when you ask, how would I prescribe it? Well, I wouldn't. I'd refer on to the gonks.
So what about if Alex had a WHO score of 7? How would that change our management?
Once the WHO prognostic score gets to 7 and above, the success rates with single-agent chemo are much lower, and so combination regimes are preferred. In some patients with a WHO score of 5 or 6, combination regimes may be considered, but this is at the discretion of the treating gynecologist and based on the presence of additional high-risk features, like an excessively high beta-HCG, for example. The multi-agent chemo regime is typically referred to as a MACO and stands for etoposide, methotrexate, actinomycin D, cyclophosphamide, and oncovin. In some of these high-risk patients, a combination of adjuvant surgery and a MACO will be required to achieve disease control.
How long do patients typically need chemo?
All patients with GTN should be monitored with serial beta-HCG measurements at the start of the treatment and then on day 1 of each subsequent chemo cycle. We also monitor full blood count, LFTs, UEC to check for toxicity. Chemotherapy is continued until we have 3 consecutive negative beta-HCG levels, which indicates remission. There is generally a further brief stint of chemo after this, which aims to prevent relapse.
So, is chemo the only treatment option, or could Alex be cured with a surgery instead?
Well, Alex could choose a hysterectomy, which would eliminate the complications of local invasion, but she also has a lung metastasis, so she is going to need chemotherapy anyway. Surgery for local invasion does not prevent metastatic disease or eliminate the need for chemotherapy or beta-HCG follow-up. GTN is highly chemosensitive, and so she is likely to get an almost 100% cure rate without the need for surgery. Thoracotomy can occasionally be indicated for solitary lung lesions, however, chemotherapy is reasonable management in the first instance.
So, what kind of follow-up is needed for Alex after receiving chemotherapy for GTN?
All patients with GTN are followed with weekly hCG levels until normal for 3 weeks and then monthly for 12 months. Recurrence rates are about 5 to 10%, with most recurrences occurring within 1 year, and so this is why monitoring extends for a full 12 months. However, occasionally, recurrences can occur afterwards, even during menopause, and so if the patient develops any concerning symptoms like abnormal bleeding, then a beta-HCG level should be obtained. Now, it's really important to avoid a new pregnancy during follow-up after treatment for GTN. A new pregnancy makes it impossible to interpret hCG results and really complicates management. Contraception is absolutely essential for the entire duration of surveillance. Typically, the combined contraceptive pill is preferred, since progesterone-only regimens are associated with irregular bleeding, which may raise concern for disease recurrence. The Mirena is contraindicated because of the risk of uterine perforation.
I thought you weren't supposed to use the combined oral contraceptive pill for GTD or GTN.
There was previously a concern that combined oral contraceptives increase the risk of GTN in patients after a molar pregnancy. However, this has been disproven with 2 randomized controlled trials. The combined oral contraceptive pill has a low failure rate and there is no evidence that they influence the course of GTN, so they can be safely used.
So what if Alex decides she wants another baby?
Women who achieve remission after treatment of GTN can expect normal reproductive function and can attempt to achieve pregnancy after 12 months of normal hCG levels. There is no increased risk of congenital abnormalities after the use of chemotherapy. Following delivery, the placenta or any products of conception should be sent for histopathology, and a beta-HCG level should be measured 6 weeks after delivery to ensure complete remission and the absence of occult GTN. And if you do happen to detect choriocarcinoma in the placenta, it's important to do a urinary beta-HCG of the baby because choriocarcinoma has been known to metastasize to the fetus.
Wow, that's crazy. And that wraps up the management of a very rare and complicated malignancy. We really haven't delved into all the nuances of GTN, but that's because it's such a rare condition that really only gets treated by gyneacologists in specialized GTD treatment centers. The information in today's episode should be a decent enough overview to give you the knowledge you need to manage patients and to pass your RANZCOG exam. So let's summarize it for you.
GTN is the malignant form of GTD and includes invasive mole, choriocarcinoma, placental site trophoblastic tumour, and epithelioid trophoblastic tumour. It occurs after 15 to 20% of complete molar pregnancies, 1 to 5% of partial molar pregnancies, and after about 1 in 40,000 normal pregnancies.
Serial beta-HCG follow-up is recommended after any molar pregnancy to assess for progression to GTN. Signs of GTN include a plateaued beta-HCG within 10% over 3 values in 2 weeks, rising beta-HCG over 10% over 3 values in 2 weeks, persistent bleeding with persistent positive beta-HCG, or signs of metastatic disease.
Factors that increase the risk of progression to GTN include age over 40, complete mole over partial mole, longer interval from previous pregnancy, uterine size greater than gestational age, a serum hCG over 100,000, ovarian thecal lutein cysts greater than 6 centimeters, a previous caesarean birth, and those who take a longer time to reach a negative beta-HCG after evacuation.
The workup of GTN includes clinical examination looking for bulky uterus and vaginal mets, bloods including beta-HCG, LFTs, UNEs, and thyroid function tests, pelvic ultrasound and chest X-ray, and CT chest abdo-pelvis, PET or MRI brain being reserved for the presence of lung or vaginal mets only. Metastatic deposits are highly likely to bleed and should not be biopsied. And unlike other cancers, GTN is a clinical diagnosis and does not need a tissue biopsy.
GTN is staged by FIGO staging and the WHO prognostic scoring system. Stage 1 is defined as persistently elevated beta-HCG with tumour confined to the uterus. Stage 2, where the tumour extends to the adnexa or vagina. Stage 3 includes pulmonary metastases on chest X-ray. And stage 4 includes metastatic disease outside the lungs, pelvis, and vagina.
The WHO prognostic scoring system includes 8 risk factors that assess the likelihood of resistance to single-agent chemo. These risk factors include age, antecedent pregnancy, the interval since previous pregnancy in months, the beta-HCG level, the site, size, and number of metastatic deposits, and failure of previous chemotherapy.
A WHO score of 6 or less means the patient is at low risk of single-agent chemoresistance, and so the patient can be treated with methotrexate or actinomycin D. A WHO score of 7 or more means there is a high risk of single-agent chemoresistance, and so the patient is treated with emacro, etoposide, methotrexate, actinomycin D, cyclophosphamide, and oncovin.
Serial beta-HCGs are done until negative for 3 weeks, and they're repeated monthly for 12 months. Contraception with the COCP is recommended to prevent pregnancy during follow-up. Recurrence rates are 5 to 10%, with the majority occurring in the first year.
Subsequent pregnancies are usually normal, but should be followed up by having the placenta or products of conception sent for histopathology and a serial beta-HCG done in 6 weeks' time.
Now, before we wrap up this week's episode, we thought we'd touch briefly on those elusive topics of epithelioid trophoblastic tumour and placental site trophoblastic tumour. What exactly are these conditions and why are they important?
So when we're talking about GTN, we're usually referring to choriocarcinoma or invasive mole. Placental site trophoblastic tumour and epithelioid trophoblastic tumour can also occur after a molar pregnancy, but it only accounts for about 8% of cases. ETT and PSTT can also develop after any type of pregnancy.
ETT and PSTT are a little bit different to choriocarcinoma and invasive mole and actually arise from slightly different cells. The trophoblastic stem cell typically differentiates into 2 types of cells, villus cells and extravillus cells. Molar pregnancies and choriocarcinoma are derived from villus trophoblastic cells, whereas PSTT and ETT are derived from extravillus trophoblastic cells.
They also differ in how they behave. One key difference is that PSTT and ETT produce very low levels of beta-HCG. They also grow more slowly and tend to produce tumour nodules within the myometrium and hang out in the uterus for long periods of time. PSTT and ETT both metastasize later in their disease course. Because of this, they tend to be diagnosed months to even years after the antecedent pregnancy.
Another difference is in their workup. Unlike GTN, ETT and PSTT do need histopathology to make the diagnosis. They're staged using the FIGO staging system alone, not the WHO prognostic scoring system. Treatment is also slightly different, involving surgery alone for local disease or a combination of surgical resection and combination chemotherapy for metastatic disease, with much lower success rates. The prognosis for ETT and PSTT is highly related to the length of time between the antecedent pregnancy and the diagnosis, with high mortality rates if the interval is beyond 4 years.
Okay, so to summarise epithelioid trophoblastic tumour and placental site trophoblastic tumour. They arise from extravillus trophoblastic cells compared to villus trophoblasts, where invasive mole and choriocarcinoma arise from. They produce low levels of beta-HCG, grow slowly, and metastasize late. They tend to be diagnosed later in the course of the disease and have a poorer prognosis. The WHO prognostic scoring is not useful, and treatment is a combination of surgery and a combination chemotherapy.
Thanks for listening to this week's episode of the Uterine Sound. As usual, you'll find our summary slides on Instagram later in the week. Follow us on socials at the Uterine Sound on Instagram and Facebook. Check out our website, www.theuterinesound.com, or email us at theuterinesound@gmail.com. Bye!